Hello everyone. Yet again, I am back with a new video, and the topic of discussion for today is ultrasound in twin pregnancy. So, as logicians, we must be very clear about what scan should be done when, especially when it comes to a dichorionic or a monochorionic pregnancy, the importance and the things which you have to look for further serial surveillance. So, why delay? Let's move on to today's agenda. So I will be giving a brief introduction of why ultrasound in twins is important, the timing of ultrasounds that should be done in a dichorionic and monochorionic pregnancies according to FOXY, that is Federation of Obstetrics and Gynecological Society of India, and the role of first trimester ultrasound in twins, and the ultrasound diagnosis of vascular complications like TTTS, TAPS, and selective FGR, and some other miscellaneous uses which are important with respect to multiple gestation. So coming to firstly, identifying a twin gestation and differentiating from singleton gestation is a very important feature of a first trimester ultrasound. And once we have diagnosed that there is twins or any multiple gestations like triplets or higher order multiples, we have to define the type of chorionicity. So chorionicity is nothing but the type of placentation. So why chorionicity is important? Because this helps us to stratify the risk, whether it is a high risk when it comes to a monochorionic pregnancy. It is associated with many maternal and fetal complications. So, and because of the vascular anastomosis in a monochorionic twin gestation, there is a requirement of serial surveillance in the form of ultrasound to diagnose different complications. So once we have identified the chorionicity, then we can go about seeing the different uses of it in upcoming scans. So coming to the timing of a ultrasound in a dichorionic pregnancy. So this is the ultrasound monitor pathway which is described by Foxy. So between 11 to 14 weeks of gestation, that is the first trimester ultrasound, we have to do a dating of the pregnancy, the labeling of the twins, the chorionicity assessment should be done, and it is best done between 11 to 14 weeks, and also screening of for trisomy 21 or screening of aneuploidies in the form of a nuchal translucency test also should be done between 11 to 14 weeks of gestation. And then the next scan should be done between 18 to 22 weeks of gestation for a detailed anatomical survey. So it is also called as an anomaly scan, where we see a head to toe anatomical survey to rule out any congenital malformations of the fetus, the biometry, whether the growth is corresponding to the period of gestation, the amniotic fluid volume. In twins, we do not go for an amniotic fluid index, but instead we go for a single deepest vertical pocket. So in each sac, what is the single deepest vertical pocket? And if it should be between 2 to 8 centimeter, if it is less than 2 centimeter, is said to have oligohydramnios, and if it is more than 8 centimeter, we diagnose to be as polyhydramnios. And a very important other thing which has to be seen in a second trimester ultrasound is the cervical length. So we have to see the cervical length, especially in a twin pregnancy, because 80% of the time there are chances of going into preterm birth. So we have to measure the baseline cervical length, and it should be more than 25 mm, that is 2.5 centimeter. If it is less than 2.5 centimeter, then we have to start micronized vaginal progesterone. If it is less than 1.5 centimeter, it has a role of cervical encerclage, that is ultrasound guided cervical encerclage or rescue encerclage. And once we have identified the cervical length in the anomaly scan, serial assessment of cervical length has to be done. And the cervical length is best assessed by a transvaginal sonography when compared to a transabdominal sonography. And then the next scan would be between 24 to 26 weeks of gestation. And after that, every scan will be after 4 weeks, that is 28 to 30 weeks, 30 to 34 weeks, 36 to 37 weeks, and at the time of delivery. So during these scans, so-called growth scans. We have to assess the fetal growth, the amniotic fluid volume, and if there is any discrepancy in the fetal growth, then we have to do the fetal Doppler. So this fetal Doppler has to be done, and the stage-wise assessment of risk has to be identified, and this helps us to decide the timing and mode of delivery. And next, as I already mentioned, in a monochorionic pregnancy, the chances of fetal and maternal complications is a little bit higher when compared to a dichorionic pregnancy. And that is why it requires more frequent follow-up in the form of ultrasound. And especially monochorionic means there is a single placenta and there's a shared vascular anastomosis between the two twins, whether it is an MCDA or an MCMA twin gestation. So that is why we have to be keen in assessing the vascular complications from 16 weeks of gestation. So as early as 11 to 14 weeks, we would do the first trimester dating, labeling of the twins, assignment of chorionicity, screening of trisomy 21, and from 16 weeks, every 2 weekly, we have to do a serial follow-up. So from 16 weeks till 34 weeks and 36 weeks, every 2 weeks, we have to do a serial follow-up. So between 16 to 18 weeks, we have to see the fetal growth, the deepest vertical pocket, and the umbilical artery pulsatility index. And at 20 weeks, we do a routine anomaly scan for both the twins, define its biometry, single deepest vertical pocket, and the Doppler in the form of umbilical artery PI and the MCA PSV has to be done, and the cervical length assessment should be done. And in an anomaly scan, we have to also see the placental location. As we all know, placenta previa is also one of the complication in a multiple gestation. Because of the huge placenta, it can encroach into the lower uterine segment. So that is why placental location is also important. So in anomaly scan, fetal anatomical survey to define any congenital fetal malformations is important. Second, the cervical length assessment is important and the placenta location is important. So these three are very important in the second trimester, that is the anomaly scan. And thereafter, every 2 weeks, we have to assign the fetal growth and see for the Leica, and also if there is any discrepancy or any lag of fetal growth, we have to go for Dopplers. Or when we are identifying any oligohydramnios, polyhydramnios sequence, we have to also see the MCA PSV to rule out fetal anemia and fetal polycythemia in cases of twin, in cases of TAPS, that is twin anemia polycythemia sequence. So coming to the first trimester ultrasound. So how do we identify twins? So always we have to identify the twins based on the presence of two gestational sacs. So as early as 9 to 11 weeks in a first trimester ultrasound, the first very important thing is to note the number of gestational sacs, the number of yolk sacs. So we have to see and we have to define whether it is a dichorionic pregnancy and a diamniotic pregnancy, or it's a monochorionic pregnancy or diamniotic pregnancy, that is MCDA, or whether it's a monochorionic monoamniotic twin gestation. So the first thing in a first trimester ultrasound is to define that it is twins. So you have to identify the number of gestational sacs, and we have to see two gestational sacs, two fetal poles, and two cardiac activities, or a single gestational sac with two fetal poles and two cardiac activities. So now the number of gestational sacs will define that the chorionicity is defined. The number of yolk sacs will define the amnionicity. Okay, so first thing is to identify the number of gestational sacs, the number of yolk sacs, and also to see the presence of cardiac activity. So in the late first trimester, we have to be able to visualize two fetal heads or two fetal abdomens or anything like two fetal heads has to be visualized in a single frame on a ultrasound to confirm a twin pregnancy. So sometimes when we are seeing on a probe, we might see one head, and then if you manipulate the probe, we can see the other head. We might get confused that it is a twin gestation, but it could be a singleton gestation. So this confusion should not exist. We have to be able to see the two heads in the same frame on a single time monitoring. So that is when we define it as a multiple gestation or a twin gestation in a precise manner. So we have defined that it is twins, and also we have to explain or counsel the mother the possibility of vanishing twin. So what is vanishing twin? In the first trimester, we see that there are two gestational sacs, two fetal poles, two cardiac activities. But after you repeat a scan in the late first trimester or in the second trimester, there will be complete disappearance of one sac. So the twin pregnancy is converted into a singleton pregnancy. So the incidence of vanishing twin is as high as 10 to 40%. So that is why we cannot confirm the twin gestation up to the second trimester. So that is at least 12 to 14 weeks. So firstly, identification of twins is the first importance of first trimester ultrasound. The second importance is to define the chorionicity. So how do we define the chorionicity? By based on these two important signs, that is the lambda sign and the T sign. As we all can see, the lambda sign, the placental tissue is going and intervening between the intertwin membrane. So it is encroaching into the intertwin membrane. So if this space is present in the intertwin membrane, so then it is defined as a dichorionic pregnancy. This space is absent in a monochorionic pregnancy. So this placental tissue will not be able to migrate into the intertwin membrane in monochorionic pregnancies, and it is called invert T sign. And this is best done between 11 to 14 weeks of gestation, because after 14 weeks of gestation, there is regression of the chorionic frondosome, and in around 7% of the cases, we cannot clearly make out the lambda sign, though it is a dichorionic pregnancy after 14 weeks. So that is why between 11 to 14 weeks, it is best to define the chorionicity. So first thing is the identification. Second, to define the chorionicity based on lambda sign and T sign. And thirdly, the dating of the pregnancy. So we have to mention and measure the crown rump length of both the twins, and we have to date the pregnancy. And in the first trimester, if the discrepancy is before 9 weeks, if the discrepancy is plus or minus 5 days, we can take the ultrasound EDD. But if it is more than 5 days, we have to take a first trimester expected date of delivery. And within 12 weeks, if the discrepancy is 7 days, more than 7 days, it's always better to take the ultrasound assignment of expected date of delivery. So that is the third important thing, that is to date the pregnancy. What is the fourth important thing? It is to label the twins. So always the twins has to be labeled like twin A and twin B, or twin 1 or twin 2. And this labeling and this assignment of the particular A or 1 to 1 specific twin should continue throughout the pregnancy. So how do we label? So the twin which is nearer to the internal os is labeled as A or 1. So twin A or twin 1. If they are next to each other, then we can decide whether the twin is on the maternal right or maternal left, and this has to be assigned in the same manner throughout the pregnancy. And when we are labeling the twins, it is always better to label like the first twin or twin A is nearer to the internal os, which is maternal left and with the anterior placenta. So like this, if we have defined the complete position of the twin, it is also easy to assess on a serial follow-up, and we will not get confused between the two twins. So labeling is also very important. And the last importance of first trimester ultrasound is to see the nuchal translucency and nasal bone. So this acts like a ultrasound screening for aneuploidies, especially trisomy 21. So if there is raised NT or if there is absence or hypoplastic nasal bone, we can take that it is one of the risk factor or it's a screen positive for aneuploidies and it requires a confirmatory diagnosis. So that is why doing an NT-NB scan between 11 weeks to 13 weeks, 6 days, when the CRL is between 45 to 84 mm, it is very important to see the nuchal translucency. And a very important other importance of first trimester ultrasound is the discrepancy of the CRL or a nuchal translucency. So if there is occurring of any discrepancy of more than 10% with respect to CRL or more than 20% with respect to nuchal translucency, it is an early predictor of twin-to-twin transfusion syndrome in a monochorionic pregnancies. So I will repeat, if there is any first trimester discrepancy of CRL more than 10% or nuchal translucency more than 20% or more than 0.6 mm, then this is an early predictor of TTTS. If there is CRL discrepancy, there might be also chances of congenital malformations or selective fetal growth restriction in the future throughout the pregnancy. So this risk has to be kept in mind and it has to be mentioned in the ultrasound if it exists. And this is also very important criteria for us to be more vigilant and do a serial surveillance from 16 weeks to rule out any vascular complications. So as I already told, the number of gestational sacs defines the chorionicity and the number of yolk sacs define the amnionicity. So based on this, we can divide the twins into dichorionic diamniotic, monochorionic diamniotic and monochorionic monoamniotic twin gestation. And amongst this also, monochorionic monoamniotic twins are at a higher risk of both congenital malformations, preterm birth and early risk of cord entanglement and single fetal demise or intrauterine fetal demise. So that is why a monochorionic monoamniotic twin gestation has to be serially followed up both for vascular complications and for any cord entanglement and fetal demise. So these are the very important things to be looked for in the first trimester ultrasound. So next, as I already mentioned, in the second trimester ultrasound, we look for the fetal anatomical survey, placental location and the cervical length. And the next important thing in monochorionic twin gestations is to look for any complications which result from vascular anastomosis. So very known complication is the twin-to-twin transfusion syndrome. So what is twin-to-twin transfusion syndrome? There exists three types of vascular anastomosis in the placenta. So there are superficial vascular anastomosis and there is deep vascular anastomosis. So superficial vascular anastomosis are always artery to artery or venous to venous or vein to vein anastomosis, whereas the deep anastomosis are arteriovenous anastomosis. So whenever there exists this deep anastomosis or deep fetal circulation, there is at a higher risk of development of TTTS when there is shift of blood from one twin to the other. So the twin which is losing its blood or sending the blood or shunting the blood is called as the donor twin, and the twin which is receiving the blood due to the shunting of blood is called the recipient twin. So that is why the donor twin is going into anemia and oligohydramnios, whereas the recipient twin will go into polycythemia and polyhydramnios. And this is staged by a well-known classification called as Twin-Terros classification. And this is very important for us to treat and manage based on which stage it belongs to. So from 16 weeks, every 2 weeks, we have to see for whether there is any evidence of OP sequence, that is oligohydramnios, polyhydramnios sequence. So in stage 1, oligohydramnios in the donor, polyhydramnios in the recipient, but the donor bladder is still present, that is the renal perfusion is still present and the donor is able to form its own urine. So the bladder is still visible. But in stage 2, the baby is gone into so much insufficiency, the blood flow to the kidneys also is compromised, and the donor uh, twin bladder is absent for at least 60 minutes of the observation. But the Dopplers of both the twins are normal. In stage 3, there is critically abnormal Doppler, especially there is absence or reverse end-diastolic flow in the umbilical artery, reversal of flow in the ductus venosus, or there might be presence of pulsatile umbilical vein. In stage 4, there is high drops of one or either twins. In stage 5, there is demise of either twins. So based on this, we have to classify, and in stage 1, we can go for an expectant management and see for serial ultrasound. But from stage 2 to stage 5, we have to manage and we have to do an intervention. So if it is less than 26 weeks of gestation, we can go for selective photocoagulation of the vascular anastomosis, including the vascular equator, which is called as the Solomon's technique. But if the period of gestation is more than 26 weeks of gestation, then we have to go for an individualized management, either an amniotic reduction or whether we go for a septal resection. So either of the two we can do based on what is the period of gestation, and we have to go for an individual approach if it is more than 26 weeks of gestation. So this is about, in brief, about TTTS. Next, coming to TAPS, which might be either a result of oligohydramnios polyhydramnios sequence or after the vascular ablation or the laser photocoagulation, some minor uh, vessels, if they are not coagulated, be slow or chronic shunting of blood from one twin to the other. This might result in something called as iatrogenic TAPS, that is iatrogenic twin anemia polycythemia sequence. So before, there was a stage-wise approach, that is the MCA-PSV, which is the best Doppler to predict fetal anemia in one twin if it is more than 1.5 moms, and the other twin if it is less than one multiple of mediums without any fetal compromise. In stage 2, it is more than 1.7 mom in donor twin and less than 0.8 in the recipient twin. In stage 3, there is critical abnormal Doppler. In stage 4, there is high drops of the donor. In stage 5, there might be demise of one or both twins. But this classification or this staging was revised by TAP Society of Fetal Medicine Association, and they told instead of defining based on MCA-PSV of both twins, the difference of both MCA-PSV is more important, and this helps in the prognostication. So they defined stage 1 as more than 0.5 multiple of medians difference, and this is called as the delta MCA-PSV. And the stage 2, if there is more than 0.7 difference, stage 3 is there is cardiac compromise because of shunting of blood. The donor twin will go into congestive cardiac failure, and which is followed by high drops and death, and that is cardiac compromise which is seen on the donor. And stage 4, there might be high drops which is developed in the donor because of vascular insufficiency, and stage 5, there might be death or demise of one or both twins. So TAPS has to be identified and we have to manage it accordingly based on the period of gestation. Next, coming to select FGR. In singleton pregnancy, we call it as a fetal growth restriction. But in a multiple pregnancy or say about twin pregnancy, we call it as selective fetal growth restriction when there is growth discordancy between the two twins. So we have to define this based on the estimated fetal weight of both twins. So we will calculate the growth discordancy by calculating the estimated fetal weight of larger twin minus the estimated fetal weight of the smaller twin divided by estimated fetal weight of the larger twin into 100. So if this growth discordance is more than 25% and or if it is associated with the estimated fetal weight less than 10th percentile of one of the twin, then this is a diagnosis of selective FGR. And also there is growth discrepancy in with respect to other fetal biometry parameters, like there is more than 5% discrepancy with respect to head circumference, more than 20 discrepancy with respect to abdominal circumference, and also the estimated fetal weight discrepancy could be more than 600 grams. So if it is like this, we have to do the Dopplers of the restricted twin and we have to manage the pregnancy as fetal growth restriction in a singleton pregnancy by stage-wise management in with respect to Figaro's and Gratico's staging. So we have to see which stage the growth restriction fetus belongs to based on Doppler parameters. And also the amniotic fluid also is important in the smaller twin because it might be reduced because of decreased renal perfusion. And this is also defined as three different types. In the type 1, the end diastolic flow is still present. In the type 2, it is absent or reversed. And in type 3, there is cyclical change between positive and negative, or that is absent or presence of end diastolic flow. So based on this, we have to do a serial monitoring of Doppler either weekly or bi-weekly and see if there is any reversal in the ductus venosus. We have to terminate the delivery based on the period of gestation by giving antenatal corticosteroids or magnesium sulfate for neuroprotection if it belongs to that particular gestational ages. So corticosteroids up to 34 weeks of gestation and magnesium sulfate up to 32 weeks of gestation should be offered to the mother if there is any Doppler changes and you are planning the delivery. So this is the importance of selective fetal growth. So what are the other miscellaneous uses in twin pregnancy about ultrasound? So firstly, to identify the conjoined twins, if there is any presence of conjoined twins, the type of conjoined twins, whether they are attached ventrally or laterally or dorsally. So what type of conjoined twins, how do we manage, and to decide the mode and timing of delivery. And the second important use is to identify whether there is any single fetal demise. If there is single fetal demise in a dichorionic pregnancy, we can continue up to 36 weeks safely by doing the assessment of the growth and Dopplers of the opposite co-twin, which is alive. But if it is a monochorionic pregnancy, the chances of death of the co-twin is around 40% and the chances of neurological impairment is around 26%. So that is why we cannot prolong the delivery and we cannot prolong the pregnancy. We have to plan for the delivery based on the period of gestation. That is the second important use. The third important use is also to monitor the growth and Dopplers of the monochorionic monoamniotic twin gestation and to decide the timing between 32 to 34 weeks of gestation, we have to plan for a delivery. So these are the very important miscellaneous uses with respect to twin pregnancy. So I hope you understood the importance of ultrasound in twin pregnancy, the role of ultrasound in first trimester and the subsequent visits, and also the timely ultrasound algorithm which has to be followed in a monochorionic and dichorionic pregnancy. Thank you. Happy learning.